Allah, we'll start. Assalamu alaikum, good morning everybody. This is Dr. Al-Awidi, R2 pediatric resident. Today I'm glad to talk about delayed meconium passage. This presentation is not uncommon here in NICU, and it has a lot of differential diagnosis. We have to know them. We have to broaden our minds when we see such babies. So to start with, there is no disclosure, and my outlines for this presentation will talk about meconium, its characteristics, and also when it should be passed, in term, preterm, and then we'll see some of the differential diagnosis for such presentation and case scenarios. Okay, so what is meconium? It's the first stool passed by a neonate. Usually it is thick, sticky. Sometimes it could be black, green, tar-like even. Okay, so sometimes even you would think this is a stool mixed with oxidized blood. Okay, so as you can see here, it is very black and tar usually. We always see it when we go for the postnatal examination. So when it should be passed, first of all, timely passage of the first stool is one of the hallmark for good condition of the baby. Okay, because the good condition of the bowels are also one of the landmark for a good baby. So in full term, usually it is passed, and 99% of the term babies, they passed meconium within the first day, and most of them should be passed within the second day. While in preterm, we can say almost 1/3 in the first day, the other third will pass it in the second day, and then the last third will has delayed meconium passage, i.e. they will pass after 48 hours. Here are some of the causes or differential diagnosis for delayed meconium passage. We can classify them into structural causes and functional causes. Okay, structural causes like atresias. Okay, if we see more of, for example, bilious vomiting, then we think more of the higher part of the GI, like, for example, duodenal atresia. Jejunal atresia, malrotation, which happens also mostly in the duodenum, jejunum. Okay, if we see more of abdominal distension, then we think more of lower part, like jejunal, ileal, colonic atresias, and also anorectal malformation. Also, other causes are functional. Okay, for example, congenital hypothyroidism, sepsis, electrolyte imbalances, and also prematurity. Now, in hypothyroidism, there are several mechanisms implicated or hypothesized for it to cause delayed meconium, deceleration, myoelectric activity, autonomous neuropathy. Okay, intestinal edema. اهلا بك اهلا بك. بس كاتب احمد من احمد جوزي يعني ولا مين؟ Okay, so deceleration in myoelectric activity, autonomous neuropathy, intestinal edema, reduction in adrenergic receptors, all of these have been implicated as causes in congenital hypothyroidism. In sepsis, the hypoperfusion to the gut, and also sometimes even the antibiotics and vasopressors, if needed, they will affect the motility of the intestines. And even the systemic inflammation itself can cause abnormalities. Electrolyte imbalances, hypercalcemia, hypokalemia will cause also dysmotility of the intestines. Okay, so most of the functional causes, we can detect them by labs. So we do TFT, we do CBC, CRB, and what is needed for sepsis, UE, for example. Okay, so we'll have some clinical scenarios so that we just spot the diagnosis and know what is the possible cause, because we have a lot of differential diagnosis. Okay, so we have to go also quick, so I need it to be interactive. Okay, so this is the first presentation. A 3.5 kg male infant was born at 38 weeks of gestation. No complication during pregnancy, during delivery. He did not bust meconium for more than 48 hours after birth. There is bilious vomiting and abdomen is distended slightly. The infant was not able to feed. So in general, what is the first possibility, general possibility? Structural, yes. So mostly something causing intestinal structural intestinal obstruction. Yes. So rule of thumb for suspecting any bilious vomiting, abdominal distension, think of structural. Okay, still can be functional, of course, but I mean you have to rule them out first. And also for the management, rule of thumb, you will put what will you do once you think this is structural? Yes, NGT decompression. You will give IV fluid. Okay, if dehydrated, you will continue also on DNS. Okay, so so this is another baby who's having bilious vomiting. Okay, antenatal scan shows polyhydramnios. There is distinctive facial features of Down syndrome and not much abdominal distension on physical exam. You did abdominal X-ray, okay, and then you have seen this. What is this? So double bubble sign in duodenal atresia. So what is the treatment? The previous management and also surgical resection. Okay, so in surgical resection, here it's the duodenum, or the the proximal part of the duodenum is distended. Okay, here bear in mind that such proximal atresias like duodenal and jejunal, they still can have they can pass meconium normally. Okay, another baby, almost the similar presentation. However, here we have in the X-ray triple bubble. So this is most likely as a differential diagnosis, jejunal atresias. Okay, so almost similar management. Okay, they still can pass meconium normally. Okay, another baby is having also progressive abdominal distension. So now go more distally. Okay, and we can see that there is multiple air fluid levels. Okay, so now we think more of something distal in the intestine. So this is ileal atresia. Okay, colonic atresia could be there also as a cause of delayed meconium, and you can see how the colon is really distended here. Okay. Okay, another case scenario. Can someone please read?
Okay, here male child, birth weight 2.7, antenatal history is normal. Past meconium, discharged after 24 hours from delivery. Presented at day 5 with yellowish vomiting, admitted and managed conservatively. He was discharged without pain, no vomiting.
Okay. Okay, so this is like the initial X-ray. As you can see, there is no air fluid levels. no double or what triple bubble signs. Just you can see that there is in the right side, there is no gas at all in the colon, a little bit on the left side along with the gastric bubble. Okay, so then this patient came again with the similar presentation. He is still having a lot of bilious vomiting. Then you opted to do next step, which is contrast study. Okay, so you have given the baby barium follow, and then you have seen this thing. Okay, you did also ultrasound. You have seen this thing. I don't know what is it. What do you think? Anyone knows? Okay, let us start with the ultrasound. Okay. It's similar to it, but it's not target. Okay. ما donut. We see it in the interception. Yeah. So this is, they call it whirlpool sign. Okay. It's like العاصفة هذه. Okay. تمام. So okay, we'll know why it is like this. And here they call it, تعرفوا هذا, what is this tool in English? Corkscrew. Yeah. Screw. Okay. So this is corkscrew sign. So these are seen in ايش الشيء اللي يسبب volvulus and malrotation. أيوة. Okay. So malrotation, then we see from the ultrasound, is it really volvulus or not, or sometimes even intraoperatively. Okay. So the diagnosis is malrotation, which might cause volvulus. So here we can see the superior mesenteric artery, and around it is superior mesenteric veins. Okay, and here the contrast will go in the intestine in its axis, يعني around the SMA. Okay, so malrotation is happened when the duodenojejunal flexure is rotated from its side. It should be in the left side. However, it should be in the left side, right? Okay, and usually even upper to the duodenal flexure here. However, in malrotation will come to the left side and also to its lower usual site. This has happened because of defective rotation of primitive intestinal loop around the axis of SMA during embryogenesis, which will result in abnormal short mesenteric root, and then it will be easy for it to twist around the SMA. Okay. Now, if this twisting causes SMA to be completely obstructed, then it is volvulus. So one of the first differential diagnosis should click in mind when you see bilious vomiting is malrotation. It's emergency diagnosis. Okay. يعني other diagnosis, like we can give them the initial management and nothing will happen to them, يعني, since they are MBO كده. But this malrotation, if it's not treated in a timely manner, then we'll have maybe gangrenous bowel and ischemic. Okay. Okay. Another baby, 3.0 kg male infant, was born term. There was no complication also during pregnancy and delivery. He did not pass meconium after 48 hours from birth. Had onset of vomiting on the first day, and his abdomen became mildly distended. Okay, the infant was not able to feed, and abdominal distension increased in the second day. And you have done digital rectal examination as part of your full abdominal exam. Okay, and you saw there is tight anus, and once you take out your finger the stool and also gas came out. So what is the differential diagnosis? Click in your mind. Hairspring disease. And the sign, do you know what is called? When you just squared sign. Squared sign, okay. So a hairspring disease is a congenital aganglionic megacolon. Okay, it is caused because of failure of the neural cell migration to the intestine, causing this myenteric plexus not to be innervated. So there will not be enough peristalsis to just take the meconium out. Okay. Its incidence is 1 in every 5,000 live birth, with the difference طبعا between the sources. It's more in males to about 4:1 ratio. 85% of time it is limited to rectosigmoid segment. Okay, and we'll see its different types. In the newborns, will present similarly to the like with bilious vomiting and abdominal distension. Okay, sometimes it's not happening in the first. It's only 50% of newborns they will have delayed meconium. The other 50s they will not have it. Sometimes they go unnoticed even to the like early years of life. So some they will be known to have hairspring when they are, for example, 3 or 5 years old because of the continuous constipation not relieved. Yeah, and also it has association with Down syndrome. Okay. Types of hairspring disease. Can someone read?
So segment, 75% rectal and distal sigmoid colon involvement. The long segment type is 15%, with typically extend to sphenic fracture and the transverse colon. Total colonic agangliosis, extension of agangliosis into the small bowel, and then the ultra short one, 3 to 4 centimeter from channel and sphincter on.
Okay, so these are the types of hairspring disease, and the treatment also will depend on which types the baby is having. So how will you proceed once you saw that squared sign? What you will do first? Abdominal X-ray, as always. Okay, so this is the abdominal X-ray. We can see that there is no air in the rectum, and distal to it the dilated colon. Okay, so you have done barium enema, and in the barium enema you have seen two things. First thing is the transition zone. So once you go into the rectum, or depends wherever the microcolon is. So you'll see transition zone here. There is no much contrast is going into the distal part of the rectum. Okay. Another signs that after giving the contrast, it will be there for more than 24 hours. Okay, so you will do another X-ray after 24 hours. You will see the contrast still there. Okay, just bear in mind that barium enema should not be given if you are suspecting also hairspring associated enterocolitis. Okay, because it can extravasate and cause peritonitis. Okay, so one of the let's say investigation we could do for the babies we are suspecting hairspring disease is anorectal manometry. So it's usually done for the infants between more than 1 month old. Okay, they just insert a balloon in the rectum. Actually, it's not here, it should be in the rectum. Okay, and here you will see this is the rectum pressure, and this is the internal canal. pressure. Okay, so internal, not external, because external is voluntary, but we are talking about the whereas the myenteric plexus is deficient in the internal anal canal. Okay, so once the normal reflex, once this stool is coming into the rectum, what will happen? The internal sphincter of the anus will dilate to allow the stool to pass. Okay, so here in the normal reflex, you can see once we instill 10 ml in the balloon, pressure will increase in the rectum, the internal canal will have less pressure. Okay, however, in the abnormal reflex in HD, we give 5 ml here, still there is no much dilation in the internal sphincter. Another 10 ml, although pressure is there, however, there is no dilation. Okay, so this is one of the investigation we do. Okay, what is the gold standard for Hirschsprung disease? To know? Biopsy. Okay, so we mostly go with biopsy. It's easier and available here. Okay, so the biopsy will show aganglionosis, and which is evident by absent carotene staining. Also, they will do immunohistochemistry staining, and they will see the hypertrophy of nerve trunks. Okay, so Hirschsprung disease, we can classify it into three categories in terms of suspicion. Either it is highly suspected, or moderately, or low suspicion. When it is high in the early in life, like babies aged from 0 to 6 months, with any of the following: delayed passage of meconium, okay, abdominal distension, associated anomalies like Down syndrome, tight anal sphincter or square sign, and rectal exam, and also family history of Hirschsprung disease. Okay, if the baby is older, age 6 months to 3 years, and he is having no stool present in rectal vault in the DRE, or tight anal sphincter, this is moderately suspected. Okay, now after we are suspecting Hirschsprung disease, we have to rule out Hirschsprung associated enterocolitis. So we see, is this baby having fever, vomiting, diarrhea, or abdominal distension? If yes, then we have to evaluate emergently for Hirschsprung associated enterocolitis. We do abdominal x-rays, okay, and also we do fluid resuscitation, NGT, antibiotics, colonic irrigation, and emergency laparotomy. This will be, done by surgeon. Okay, for us, we have to start with the initial management. Now, if there is no signs of enterocolitis, then we do what is called unprepped contrast enema, i.e. we don't give the baby any stool softener. Okay, we need the stool to be there. Okay, or we do rectal suction biopsy or anorectal manometry if more than 1 month old, of course. Okay, if any of those is abnormal, then we know that this is Hirschsprung disease. If it is normal, this is most likely functional constipation. Now, if no one of these conditions are fit, but still the baby is having refractory constipation, then this is low suspicion for Hirschsprung. Okay, we still go with abdominal X-ray. If there is no stool in the lower rectum, but he is having severe symptoms, then we still do the investigation for Hirschsprung disease. Otherwise, mostly the diagnosis will go with functional constipation. Okay, what is the treatment for Hirschsprung disease? Okay, what they call it, the procedure, do you know? Pull-through procedure. Okay, So sometimes they will, it depends on the type, the sites, and the clinical condition of the baby. Either they will go immediately for just one staged surgery, which is pull-through procedure, or they can just start with the colostomy. They take the rectal biopsy, then accordingly they will resect. Okay, according to the biopsy. Okay, another entity causing delayed meconium passage is small left colon syndrome. They will present with in the X-ray with abrupt smaller intestinal caliber, more from the splenic flexure of the colon and downward, but it spares the rectum. It is not that much common. About 50% of the babies, they will be infant of diabetic mother. What is the pathogenesis? As you know, the infant of diabetic mother, they will have a lot of sugar intrauterine life. They will have a lot of also insulin. So once they are delivered, this insulin will be there. The hypoglycemia will take place, and then glucagon will also will be high, so that the sugar will increase. This glucagon it is hypothesized that it causes constrictive effect on the left colon smooth muscles, causing this obstruction. But this is transient obstruction. Okay, so usually it relieves by 24 to 48 hours, and if it's not, then we can give barium enema, and usually it is diagnostic and mostly therapeutic. You can see here from the splenic flexure how small caliber is the descending colon is. Okay, any question do you have? Till this moment, everything is clear. We have a lot of differential, I know. Okay, great. So let us go to another great entity, which is Meconium ileus. Okay, Meconium ileus, it happens in the small intestine, first of all. Okay, it is caused by sticky meconium in the small intestine. It is hypothesized that it is caused by abnormal in mucin production by the pancreas or any other, okay, which could be caused by cystic fibrosis. That's why when you see Meconium ileus, you have to rule out cystic fibrosis. You have to do a sweat test, sweat chloride test, and other investigation for cystic fibrosis. Okay. Either cystic fibrosis or any other pancreatic exocrineopathies which cause less mucin. Mucin function is to degrade mucus. Okay, so once it is in a low amount, this mucus will be very sticky and will cause this meconium to be insipidized in the small intestine. Okay, so you can for the diagnosis, you can start with always as abdominal X-ray, and you will see soap bubble sign. Okay, because the like small intestine gas will be entrapped into that meconium. Okay. Yes. So okay, here the soap bubble sign. Okay. And here, when you do the contrast follow through, you can see that there is meconium here in small intestine. And also, you would see another sign. Do you know what is it in the X-ray? Billet sign. Yes. Okay, this one. And also small colon, small caliber colon. Okay, or called small left colon, because of what? The meconium is not passing. So with the ileal atresia also, you will have this small colon. Okay, so treatment, usually it is simple. Okay, you will do gastrographin enema, and if it's not unsuccessful, you would go for operative evacuation. They will do milking. okay, intraoperatively, or they can instill irrigation by saline, N-acetylcysteine, or gastrografin. Okay, but sometimes it is not simple meconium ileus. The baby will not be clinically well. Okay, sometimes he might have also perforation. Then this is a surgical emergency. Okay. I take opportunity just to talk quickly about meconium peritonitis. What is it? It is presence of sterile meconium in the peritoneum as a result of intrauterine perforation of GI. Okay, so usually this happened in the intrauterine life. It heals also in the uterine life. It is a common cause of peritoneal or peritoneal calcifications. Okay, or even scrotal, because the process vaginalis sometimes could be still patent, and this meconium will go into the scrotum. It is associated with cystic fibrosis, atresia, polyhydramnios. Okay, because those will cause perforation. Okay, might cause also intestinal obstruction by fibroadhesive bands as a result of the inflammation. Okay, so here you can see the calcification and the ultrasound. Usually no intervention needed, okay, because it's usually healed intrauterine life, unless there is ascites, intestinal obstruction, and meconium podocytes. Usually we just follow it by ultrasound during the pregnancy. Okay, another clinical presentation, can someone read?
3 kg male infant was born after 40 weeks gestation. There was no complication during pregnancy or delivery. He didn't pass meconium in the first 24 hours of life, and he had the onset of vomiting on the first day. Has abdominal distension, DRA revealed normal penis.
Okay. Then you have done abdominal X-ray. Okay, it was just a little bit of distension in the proximal or the descending and ascending and transverse colon. But then you went to into the contrast, okay, investigation, and you have seen this. So what do you think is the cause? You have also small caliber. Okay, Meconium plug syndrome. Okay, so actually this this picture, you can see it in other, even like in small left colon syndrome. You can see the same thing. Sometimes it can come together, but they are different entity. Okay, so small left colon usually more in like in term compared to the meconium plug, which is more in the premature and preterm. Yes. Okay. And contrast cinema could be diagnostic and also therapeutic in meconium plug syndrome. Okay. So it is mildest and most common form of functional distal obstruction in the newborn. So most of the delayed meconium is caused by meconium plug syndrome. I put it in the last because it's associated with a lot of the other causes. It's like a presentation of other causes rather than like a diagnosis itself. Okay. Usually, okay, this is the meconium plug, and it has this whitish hard cap. Okay. Etiology is not clear. Sometimes some they hypothesize that it is transient functional of colonic immaturity of mesenteric nervous system. Okay, so the peristalsis will not be much effective, causing meconium to remain longer, and this lead to the water absorption will be done by the colon, causing it to be much sticky. Its incidence is 1 case in 500 to 1,000 neonates, so it's something common. Association, this is very important. It's associated with a lot of differential diagnosis. Of course, prematurity is the first one. Hair spring disease, infant of diabetic mother, small left colon syndrome, Meconium ileus, also some medication which will be given, for example, for preeclampsia, magnesium sulfate or tocolytics. Okay, again because they cause this also the abnormality in intestinal motility, and also hypothyroidism, again intestinal dysmotility. So usually we start with just rectal stimulation, okay, to stimulate the peristalsis. We can give also barium enema if they are if those treatments are ineffective, then we can go for surgical evacuation. Okay, here another baby, okay, almost similar presentation, but this is within hours. It has abdominal distension increasing, okay, and when you did the full exam, the anus is not there, okay, so the diagnosis is anorectal malformation. Anorectal malformation could present differently. You can see here, okay. Okay, so this is just to bear in mind how it could present in real life. Okay, so we don't need to know their types and the high type, low type. That's more for surgeons. Okay, so the treatments we refer to surgeon. Some they do immediately anoplasty. Some they do start with colostomy followed by pull through after 3 months. Okay, so these are most common differential diagnosis. So our take-home message is: delayed meconium passage raised suspicion for functional and structural abnormalities. It is crucial to suspect intestinal obstruction in a timely manner with the proper investigation and treatment. Intestinal atresia is present at birth but still can pass meconium, especially if proximally placed. Malrotation with volvulus is surgical emergency. Okay, any babies with bilious vomiting, don't forget this differential diagnosis. Hair-spring disease can be discovered in neonatal period, but also some of them they will just present with refractory constipation later in life. Contrast enema is diagnostic and therapeutic in meconium plug syndrome, neonatal left small colon, and meconium ileus. You have to suspect cystic fibrosis in any baby with meconium ileus, and child having anorectal malformation with fistula may be helped with opening the fistula more to evacuate the bowel movement until definitive surgical correction takes place. These are, thank you very much. Okay, that's it. Okay, these are my references. If you have any question, welcome.
I think very comprehensive and getting all the details short, which is very nice. Appreciate the X-ray and very study that you showed also. I think all of us we need to know in between and refresh our mind about all these causes.
Sure.
Thank you so much.
Thanks. No question. Thank you very much. Okay.
كنت محمد الكمزاري came to us. Welcome. This is our best friend.